Welcome and thank you for coming to our quarterly program where we get to hear from folks who are a whole lot smarter than me and share a lot of information that I think you'll be really interested in. And Chris has volunteered his home for both hot and cold therapy after this, if you are at all interested. Thank you again for everybody for coming. We have some foundation board members in the room, Susie Donahue, and I'm trying to see if there's any others. Barb right there. We also have some from our exec team. Will, thank you for making time for this important conversation. I'm not going to go into a lengthy introduction of our two speakers. I had the benefit of getting to know them over about a week-long time in Costa Rica and got to know Chuck and Ashley. You will absolutely enjoy the talk today, and so I will turn it over to them.
Good.
Hi. So my name's Ashley Mason. I'm a professor at the University of California, San Francisco at the Osher Center for Integrative Health, and I'm very excited to be here talking with you today. I wear a bunch of different hats, but today I'm going to focus on two hats. One is my work in depression research, and one is my hat in insomnia treatment and research. So before we start, a couple of disclosures. I do some consulting occasionally. But let's dive in. So in the United States, we're prescribing more and more antidepressant medications to hopefully lift people out of the blues. They're easier than ever to get. There's generic versions of almost every antidepressant medication you can think of. Primary care doctors can prescribe them and oversee their implementation. And yet, as more people are prescribed antidepressants, there are more and more people with depression. What you can see in the brown bars in this graph are people who are taking one or more antidepressant medications. And sadly, what you can see is this green line, and that's the rate of suicide that is going up and up. About 30% of people who try an antidepressant get some benefit. But that means there's 70% of people who need more or different treatment. We need to do better. And I want to start today's talk with some really old news for you. People have been manipulating temperature to help them with physical, spiritual, and mental health for thousands of years. And many people in this room would probably agree, right? Going in a hot tub or a sauna is pleasant. People have done this, yeah? These things, they feel good and we enjoy them. But interestingly, the heat sounds nice, but in a lot of these cultures, people are plunging into ice-cold lakes and rivers in between heating sessions. And you see this in the Finnish sauna tradition, the Russian banya tradition. It's everywhere. So people must be doing this for a reason. And most of us can agree that the heat feels good. But there's probably only one person in this room sitting here craving going into an ice bath right now, and that's Chris Lindley. So, and nowadays we're seeing ads suggesting, oh, go into this cold plunge for your brain health, to lose weight. But I don't think people thousands of years ago were really concerned about those things. But things that they probably were concerned about are still things that we are concerned about. And some of the top of mind ones that we can think of are pain management, right? Anybody ever hurt themselves and been told, oh, ice that. It helps with inflammation, right? And people probably also, well, maybe in this room people may not know, but a lot of people have said that their mood feels better after they soak in an ice cold bath of water. And we know more about how these things might work now than we ever did before. Thousands of years ago, people weren't measuring their norepinephrine or their inflammation markers to see if it was helping them. They just thought, oh, this is helping me. So they kept doing it, right? And I have some more old news, but it's a little bit more recent. In the past 5-6 decades, we've learned a lot about the correlations between temperature and depression. And decades-old data have shown that people with depression often have higher body temperatures, and they have lower circadian temperature amplitudes. What does that mean? That means that during the day and during the night, across the course of a 24-hour period, the highest body temperature that people get to and the lowest body temperature that they get to, those are not so far apart for people with depression. They're operating in a narrower temperature range than people without depression. And a few really intriguing studies have found that when people feel better, their body temperature decreases, and that circadian temperature amplitude increases. And let me be clear, there's so many ways to be depressed. Some of you may know that there's actually 9 criteria for depression. You have to meet 5 of them in order to be depressed. And of those 5, at least one of those has to be one of these particular 2. So there's so many different permutations. A person with depression might totally be unable to sleep and have no appetite. Another person with depression might be sleeping all the time and ravenous, right? So we can't talk about people with depression as one group of people. And this temperature story, it may not be the case for everybody, but I want to make the case to you that it might be telling some people's story. And, So before I make an arguably provocative hypothesis, I want to zoom in on our data that we actually collected during COVID, which I stumbled into collecting. It ended up being a 65,000 person study that I never meant to do. And it was focused on measuring body temperature to see if we could detect COVID. And at the end of the day, of course, I'm a clinical psychologist. So as we're starting this study, as we're about to launch it, I throw in some measures of depression to say, okay, we're going to be collecting all this data from tens of thousands of people. We might as well also see if we can measure their mental health. And participants in this study reported on their body temperature that they took with a thermometer like the one you have at home. And they also wore one of these rings that measures their body temperature 1,440 times a day. That's once per minute every single day. And you don't need to know statistics to see what's going on in these pictures. What you can see here is that in the red line, those are the people with the most depressive symptoms. And the green line are the people with the least depressive symptoms. And on the y-axis, that vertical axis, is body temperature. So you can see the people with the most depressive symptoms had the highest body temperatures, and the people with the least depressive symptoms had the lowest body temperatures. Before this analysis, the largest study to date looking at this idea had a few hundred people in it. This analysis has about 21,000 people in it. So I'm convinced that there's something more going on in this story than I was. I'm more convinced now than I was after reading all of the small studies. And so now that arguably provocative hypothesis I want to make, thermal dysregulation, it might affect a substantial number of people with depression. And it's no wonder that we're living in this modern world with air conditioning and heating. We expose ourselves to so much less thermal stress than we did hundreds of years ago. We live in this narrow temperature band. Everybody ever heard the phrase, use it or lose it? We're not really using our thermoregulatory flexibility a whole lot in our day-to-day lives. And so if we're not using it, are we losing it? Are we losing our ability to cool ourselves down very well? And then is this having downstream effects that are ultimately leading us to feel more depressed? So I want to pose to you that reintegrating thermal stress, for example, acute heat stress, like I'm going to talk about today, or contrast therapy, Chris Lindley's favorite, it could be an antidote for some people with depression. And I think that there's a lot of clues that support my hypothesis. If we think about exercise, for example, what happens when we exercise? Our heart rate goes up, we get hot, and we start to sweat. So yes, you're working out your muscles, you're exercising your heart, but you're also working out your thermoregulatory system, right? There's a lot of temperature changes that happen when you exercise. And running does work, by the way, for depression. There's actual peer-reviewed studies published showing that running interventions work for depression. The problem is how many people don't actually do the running they're told to do in those studies. It is much easier to convince people with depression to take a pill, and people are much more adherent to taking pills. But speaking of pills, about 20% of people who take selective serotonin reuptake inhibitors, or SSRIs, you know what the number one side effect that they complain about is? It's kind of given away here on the slide. It's something called hyperhidrosis, which is a really fancy word for sweating. And remember the statistic I started with? About 30% of people find that an antidepressant helps them. About 20% of people are reporting problematic sweating when they take their antidepressant. No one has ever studied whether the people who are sweating when they're taking their antidepressant are the people who are feeling better either. Shockingly, right? And perhaps not surprisingly, or surprisingly, depending on how you look at this, pharmaceutical companies are coming to the rescue to help you with the drug they can prescribe you with your antidepressant called oxybutynin chloride. And what does this do? This prevents you from sweating when you take your antidepressant. And they published a paper showing that it works. But you know what they didn't publish in that paper? How it affected your depression. Just that it did, in fact, stop your sweating in response to your antidepressant. So all this to say, I can't help but wonder if sweating has something to do with this story of body temperature. And I wish I had a picture for you to show you on a slide. I still regret this, of my boss's face when I walked into his office one day and I said, you know, I really think we need to put a sauna in the middle of the hospital. And now I surprise him a lot less. When I asked him about plumbing for a cold plunge, he was like, oh, okay. So as much as I want to tell you all about how I got into this work in the first place, I see the clock ticking, but I'll just let you know that I love hot summers. I love getting into the car when it's like a really hot car seat and the car has been baking in the sun. And it's not an accident that I went to Tucson, Arizona for graduate school. And that's where I met Chuck a long time ago. Before he was there, he was actually visiting the University of Arizona, and we met on one of his visits. By the time he got to the University of Arizona, I was off to the Bay Area. But in 2016, Chuck published one of his dream depression studies. And in that study, he randomized 33 patients with depression to get one active heat treatment or one fake heat treatment in this device. You might be looking at that and saying, that doesn't look like a sauna. And you're right, it doesn't. But this is a medical hyperthermia machine. And you can see this person's head is sticking out of the machine and their body is all in the machine. And what this can do is it can really heat up your body. And in this study, what they did was they really heated up half the people, and then the other half of the people, they kind of just turned it on a little bit, and they didn't get really hot. But the people who they really heated up, they were measuring how hot they were making them, and they were measuring them the way that you're imagining right now. They were wearing a rectal probe the whole time to make sure that they got to exactly 101.3 degrees Fahrenheit and not hotter. And believe it or not, 72% of the people who got the fake heat treatment session, they thought they got the real deal. So that means that it was a credible placebo, right? That's pretty good. It was a pretty good way to fool people.
Really good.
Hard to do. And what you see in this picture is that the people who got WBH, which stands for whole body hyperthermia, they had a rapid reduction in their depression symptoms 1 week later. And what you see in the circle dots that are not filled in, those are the people who got the sham treatment. They didn't have anywhere near the drop that the people with depression had. So I saw this graph in this paper that Chuck published, and I said, no. One sauna treatment and this? No. And I called Chuck and I said, I gotta do this too. This is a little bit too exciting. Because what you don't see in this graph is that there was another very, very small paper that they published that they didn't include a graph. And what they found was that they put 12 people in the same thing. They got the active heat treatment. And the reduction in depression after that one heat treatment was correlated with the reduction in their body temperature, which fits the theory, right? So that's pretty exciting. And I was hooked, but I was totally taped up by the medical device red tape. I thought, oh my gosh, how am I gonna do this? And so I spent a year searching, and I found a commercially available sauna device that looks like this. It looks a lot like the Heckel HT3000, except for it's a very, very, very small fraction of the price, and it's commercially available. And someone in Berkeley happened to have one. So I called them on the phone, and I said, hey, I heard you sell these things, and I have no money, and here's what I'd like to do. And he said, okay, well, I have a truck, so I'll just bring it to you in the hospital tomorrow. I said, oh, okay. So fast forward, and I took all the luck that very nice man gave me, and I developed a protocol to use this device to do exactly what Chuck had done in 2016. And what we found was that in people who we recruited, healthy people who we recruited, we still saw reductions in their depression symptoms. These were definitely not depressed people, and I know that because we screened them for depression when we let them in the study, and they had to not be depressed. And even within this group, they had reduced depression symptoms after one sauna session. So this was all of the data that I needed to move forward in this research, except I had a very important conversation with Chuck about this as I was going forward. And he said, Ashley, this thing happened in our 2016 study where the patients who were getting these hyperthermia sessions, they started talking to the staff. And the staff weren't really sure what to say, because these were people with depression who had come in for their sauna treatment and weren't very engaged because they were very depressed. If you've ever had a friend who's had depression, you might have noticed that they're interpersonally a little bit disengaged, harder to connect with, right? And something was happening in these hyperthermia sessions, and patients were starting to talk. And when Chuck told me this, to say that a light bulb went off in my head would be an understatement. Because if we were actually heating these people up physically and warming people up physically and warming people up socially, this is a big deal. Because when we want to provide a treatment to people for depression, we can't really do a good job of that unless we're able to engage them. We have psychotherapies that do work for depression. Many of you may know this. But if a patient isn't able to engage in the treatment will not work. So what if this is an incredible opportunity where heat is a linchpin that's going to allow us to engage people with depression in effective psychotherapies that will give them the kind of tools that they need that will last a lifetime? So I saw this as a golden opportunity because we know that cognitive behavioral therapy, which teaches people how to notice and change patterns of thoughts and feelings and behaviors, provides skills that are useful across a whole lifespan. And I like to joke that cognitive behavioral therapy is a lot like Santa Claus. Once you know he's not coming down the chimney, you can't unknow that, right? And once you understand some of these links between your thoughts and your feelings, the cat's out of the bag. And so as an example, I want to walk you through a tool. Okay, people with depression often wake up really early in the morning and they're worried. So let's say we have a person who wakes up at 4 in the morning with depression, and they're already worrying, I'm never going to make it through this day at work. I'm never going to. And if I ask that person, what % would you say you are sure that that's true, that you're never going to make it through this day? They would say, 100%. I am not going to make it through this day. And then if I call them at 11 a.m. and I say, hey, how sure are you that you're not going to make it through this day? And they'll say, I don't know, I'm like 70% sure I'm not going to make it. And then if you call them back at like 4:45 p.m., 15 minutes before they got off, and I say, hey, how sure are you that you're not going to make it through this day? And they'll say, oh, no, 0%. I made it through this day. I got this, 15 more minutes, right? And if you ask someone to do this day after day, and you literally have them write down how much they believe a thought throughout the day, and then you look at this week with them together, and you take a moment for them to realize, I don't believe that I'm not going to make it through this day at 5 a.m. because it's true. I believe this because it's 5 a.m. How true can a thought be if you believe it at different levels across the course of the day? If you're sure something's true at 5 a.m., why wouldn't it be true at 5 p.m., right? So once you're able to engage with someone in psychotherapy, they're able to shift these relationships to their thoughts, realizing, I don't believe these thoughts because they're true sometimes. I believe them because of the circumstance that I'm in. Anybody ever heard the phrase, don't believe everything you think? Right? So engaging people in these kinds of processes is much easier when you can actually engage them. And if heat therapies are opening people up to be able to do this kind of engagement, that's a big deal. So I pitched this idea of combining a mind and body treatment, the mind treatment being cognitive behavioral therapy, and the body treatment being whole body hyperthermia, to some philanthropic funders and to the National Institutes of Health, the government. And I was fortunate to get some funding to do a series of pilot studies to test this mind-body treatment. And these pilot studies are focused on feasibility, right? So the primary question was, can we do this treatment with depressed people? Not necessarily, does it work? Of course, we like to know if things work, but first we need to figure out, can we do this with this population, right? And so the treatment I designed actually included 4 whole body hyperthermia sessions in this dome, okay? And 8 cognitive behavioral therapy sessions with a therapist. And those would be about weekly. And the hyperthermia sessions were about every other week, okay? And this is a manualized psychotherapy. It's very kind of cookbook, and it can be taught to all different therapists, and you can code therapists recordings of their treatment sessions with their patients to see how well they actually did the treatment. So it's very nice and measurable, okay? And I should note, people did not do therapy while they were in the sauna. These were separate day activities, okay? And here you can see the data from this first study. We found extremely meaningful reductions in depressions, almost 16 Beck depression inventory points. And for reference, 4 points is considered clinically meaningful. And of the 12 people who finished the treatment, 11 no longer met criteria for depression at all. So we published this, and I can connect with Chris to make sure you all have a copy if you'd like to see a copy of the paper. And now we're finishing a second trial with 30 people, and we're almost done with that. And in the next phase of this work, we're hoping to expand to other hospital sites, including the Cleveland Clinic in Ohio, Mass Gen, Harvard, and then, of course, here in Vail. So before I close, I'd be remiss if I didn't touch on sleep, because this is my other temperature-related passion point. I do limited clinical work these days. I mostly do research, but the clinical work that I still do is in sleep, because it's just so good. But some 10% of the people in this room are going to experience insomnia at some point in our lives. And we often think about circadian rhythm when we think about sleep, right? But there's a word missing there. I think you should be thinking circadian temperature rhythm. Because when you think about your circadian rhythm, it's that nice sine curve, right? That's actually your body temperature. Your body temperature is supposed to be the coolest when you're sleeping and the highest when you're awake. Okay? And when we think about sleep and we think about circadian rhythm, right, people often think about sleep medications or sleep supplements. Oh, I'm not sleeping well. I must need a melatonin, or I must need a drug to help me sleep. And there's, this growing what we call the ANA trend out there. There's the Ambien to help you sleep and the Adderall to help you get up in the morning. And I'm seeing more and more of this in young people. Something to get me to sleep, something to get me awake. Don't do that. There are better options that we know available already. And it's a big, big problem. How many people know at least someone who's tried a supplement or a medication for sleep, right? Almost everyone. So I think we can do better. We know that cognitive behavioral therapy for insomnia works. The American College of Physicians said in 2016, this is the first-line treatment for insomnia. If you have insomnia, you should be doing this before you try a medication, period. It's available in a lot of formats. You can buy a self-help book to do it, you can get an app to do it, or you can get a therapist like me to do it. There's a lot of different ways to do this. And most people get big benefits, but what if we can capitalize on what we know about body temperature to do better? What if, like the depression work I talked with you about earlier, we can make a mind and body approach that's going to treat different targets in insomnia? Because some people might benefit by retraining their circadian temperature rhythm using a body-based approach. And this is kind of old news. Data across cultures have suggested that things like this might work. What we call before bedtime passive body heating can help people fall asleep better. Anybody ever been in a hot tub before going to bed and found, oh, I'm pretty sleepy now, right? So it's the generations before us would say this is as obvious as chicken soup for a cold, right? Use heating before going to bed. And nowadays, we actually know more about why that might work. When we heat up our hands and our feet in particular, and our extremities, it opens up our vasculature so that we can dump heat from our core. And that helps reduce our core body temperature. Remember that graph I showed you? When you're sleeping, your temperature is supposed to be the lowest. If you open your vasculature, it's easier to expel heat. And to assist that process, a little gentle body heating at night can do the trick. So in the fall of 2024, I'm going to be starting a new treatment study, and we're actually going to be recruiting nationwide. So people who are getting this treatment can live anywhere, including here in Vail. And we're going to be providing passive body heating at home using an infrared sauna blanket. And then we're going to have people do cognitive behavioral therapy for insomnia on the web. So I'm pretty excited about figuring out how we can start to move some of these body-based treatments into people's homes in addition to having people come to the hospital to get things. So I'm convinced that there's something here with the temperature story. And although some people's physiology may be robust to our modern day narrow thermal window that we're living in, not everyone may be so lucky. And I want to close by sharing a few of the questions that I have at the intersection of thermal treatments and depression, some of which I think we're actually very well poised to work on here at Vail. So can we identify the people who might be the most likely to benefit from this? I mean, are the people who are walking around with higher body temperatures going to be the best people for this kind of treatment? And can we measure that using an ambulatory device like this to see, oh, who might benefit from this treatment? And how hot do we really need to get people? I mean, the rectal probe 101.3 degrees protocol, I'm telling you, it's pretty intense. Chris can tell you too. It is not a gentle sauna at the spa, okay? It's an intense heat treatment. We are forcing your body to sweat. And we don't actually know how long we should have you at that temperature. We keep you there for a couple minutes because it's what we've always done, but are there benefits to being at it longer? We don't really know. And is cold contrast part of the story for some people, for everyone, for no one? We don't really know, but for thousands of years, people have been doing this probably for a reason, right? And can we use biological signatures to time treatments? Could people be wearing temperature devices that are measuring their body temperature that tell them, oh, now's a good time to go get in the sauna. Now's a good time to go do this other treatment, right? Can we use these simple non-invasive procedures to do that? And do we all have to do it in the hospital? Can we figure out ways to do this at home? Maybe people come in to get an intense treatment at the hospital, but maybe we can do less intense treatments at home using commercially available sauna blankets. We just don't know. We have a lot of work to do. And then, of course, there is an elephant in the room, which is that, you know, these body-based therapies, they don't make people disclose. And not everybody wants to disclose. And by disclose, I mean, some people don't want to talk about it. They don't want to go to therapy. They want an alternative that doesn't require them to get there. And maybe this is a good option for some of those people. So I'm pretty excited about a lot of these things, particularly heat treatment for depression. And I hope you've warmed up to it too. Thank you.
Good. So I've got a few minutes. I wanted to follow up on what Ashley talked about. You can see it's really interesting, right? You can see why those of us that work in this space are so interested in it. I wanted to talk about how it fits into what we're doing in Vail at the Behavioral Health Innovation Center. So let's dive in. This is what you will find on our mission statement on our webpage, which we need to update a little bit as I was looking at it. But it says, Vail Health is committed to making the Innovation Center a world-class destination for behavioral health research, treatment, and education. Well, we're doing hopefully a little education now. But I want to talk to you about the research. I'm a researcher, and that, of course, is where that's the flagship efforts, especially in the beginning, that we're doing in the Behavioral Health Innovation Center. And we have a not-so-secret, top secret plan for success. It's got 3 elements, and I want to talk about them. This is the first one, and this is how I got into this, which is leverage the incredible clinical developments in behavioral health that's been occurring here, right? So Mike Shannon, who endowed my work at UW, told me I had to come out here. Many of you maybe know this story. This was 2022, and meet with this guy, Chris Lindley. And so, you know, I think maybe Mike was thinking I'd come out there, kind of razzle-dazzle him with the research. I was so moved by what I saw they were doing here clinically. I was at that, what's that place called, the Gas House or something like that, the little divey joint, yes, right, you know. And I was trying not to let a little tear come down my eye because I'm a psychiatrist. I've been dealing with mental health forever. And I was so moved by what you folks are doing in this valley that I said, if I can be part of this, it's not that I really need another job, but I'm so moved by this, I will come, I will do this. And that's what I'm doing here, right? So, I really only have 1 minute and 52 seconds?
Oh, it's going on.
Oh, good. All right, that would be tough. So anyway, this is an amazing resource that we have here in this valley. It is absolutely unique in the entire world as far as I know. So that's the first one. Second one, take a lesson out of the SPRI, the Stedman Philippon Research Institute playbook, which is build immediate research infrastructure, a la people like Dr. Mason, and expertise by partnering with well-known, based on years of collaboration. That's an important thing I'll talk about in a second, and trusted world leaders in the relevant disciplines. I'm an old guy. I've been kicking around this space for a long time, and I know the world's greatest researchers, right? If you want to do hyperthermia, you want Ashley Mason to be working with you on your studies, right? And we can make a list of the things we're doing, and I don't have to have all the brains in the world. I know all these really wonderful people. And so one of the things we've done very quickly is pull in these research, universities that are mired, oh my God in heaven, they're mired in bureaucratic problems, they're slow. We are a wonderful place for them to work with because here we're fast, we're supple, we can do things quickly. We have these sort of amazing clinical development. But these places are powerhouses of intellectual strength. So Wisconsin, there's actually a consortium between the Behavioral Health Innovation Center and the University of Wisconsin. Ashley's at UCSF. We're going to do some interesting work with a world leader in social genomics at UCLA. Emory University is much involved in the work we're doing. So you get the idea. So basically, it's not just Vail. We're now becoming a hub of pulling in the country's top academic research institutions. 3, ask the right questions, study the right things, and do it in the right way. Because, a lot of research is sort of redundant, dull, and kind of the version my mom used to talk about, she lost her religious faith in college. I was just thinking about how many angels can dance on the head of a pin. A lot of research is these sort of things. We don't want to do that here. We want to do research that is impactful and has clinical relevance and is scientifically cutting edge. So, we've taken that idea, and it's an algorithm for the first phase of studies that we're doing in the Behavioral Health Innovation Center, and it has its own set of rules. So here's the first one. Identify novel treatments with a strong scientific rationale and empirical evidence of effectiveness. So there's all sorts of things people try for things like depression, for things like substance abuse, because these are deadly, dangerous, difficult to treat disorders. And some of these things are miracle cures for some people. Many things that help individual people do not pass the test of clinical trials, where you have to say, in 100 people, 50 people who got whatever it is did better on average than, say a placebo. That's a much higher bar. We want to start with interventions that are novel, that are not just another antidepressant pill, they're doing something different, but there is already empirical scientific data to support them. So we've heard about hyperthermia. It works. You take people that are really depressed and you cook them up the way we cook them up. Not everybody will feel better, but many people will feel better. The data for the other thing we're looking at, we'll talk about in a second, psychedelics, which have been a lot in the news, there the data are becoming overwhelming. So we take things that there's evidence that they work, and we conduct studies here that benefit patients in our catchment area by providing these treatments to everyone enrolled. So in this first phase, no placebo arm. So usually, let's say you come into a hyperthermia study, but let's think about something else. Let's say something like psilocybin, a psychedelic. You come into my study, and I say, well, sir, you got a 50% chance of getting psilocybin, and you got a 50% chance of getting a sugar pill, right? Well, if you're desperately depressed, it's kind of a bummer to go through all this stuff and get a sugar pill, right? So in our studies, whether it's hyperthermia or whether it's psilocybin, everybody gets that active treatment. So anybody that comes into the study has the opportunity to benefit from treatments for which there are already scientific data, even though they're normal. But If you just stop there, it's just kind of a fancy clinical program. We have a charge to do cutting-edge scientific research. So then, though, you take that, and on top of that, you enact cutting-edge designs to better understand how the treatments work, how they can be made to work better, and who is likely to obtain the most benefit or suffer the most harm from these treatments. And I'm going to talk to you a little bit about how we're doing that. So you don't just quit by giving people the treatment. You design studies that help you understand how can we make these treatments for which there's already scientific evidence work better. And then when we do that, we can optimize how we offer them to people here and then hopefully, out into the wider world. So let me give you an example, and we'll talk about hyperthermia. And start with this question, can millions of Scandinavians be that wrong? Ashley had that nice list of things that we don't know for hyperthermia. And there's a lot of things we don't know. I mean, she already articulated them. We could pick any one of them. But as we thought about what do we want to pick, we decided that this really key, obvious, pressing issue is, all over the world, when these things are used as ancient practice, I'm a Californian, including in native groups in California, they're almost always paired with cold. There's a little bit of evidence that cold itself may have benefits. More evidence for maybe the health, physical stuff than the mental, but there's a little bit. There is no study where anybody has ever looked at people that go into something like a sauna and then jump into the river. Even though millions of people do it, nobody has ever studied it, and we don't know if heat works, can we make it work better by adding cold? Maybe we can, maybe we can't. But it's a scientific question we can answer, right? So we can do a study where we can take people that are depressed, we can enroll them, and we can give everybody heat because we've got really good evidence that heat works, and then half of them can just stay hot, and half of them can go into the cold plunge right afterwards and freeze their butt off, right? And then we can say, does freezing your butt off in the cold plunge, up the ante for the response? Let's say it gives you 30% more response. Well, then you go, listen, I know it's cold, but, this is going to really make you feel better. Or, if we find out that most people that are depressed go, oh, well, that heat was rough, but I'm not getting into cold. Well, then not only, it may work, but you can't get people to do it. That's important to understand. Or it may not work. But we're going to ask that question, and this is going to be the first place in the world. I was using this analogy today with Will and you guys, that is sort of like, if you like football, when the line works right, they open up the hole, and goes the running back, right? It's like the same thing. We've opened up this amazing opportunity. Nobody has asked this completely brain-dead, obvious question. We're going to study it. That is a core thing we're doing in this chilled study. We're doing something else, which is this. So Ashley mentioned a smaller study we did years ago. One of the other things we saw in a very small, just 3 or 4 people in this small study was that the 3 or 4 people that were taking an SSRI did not benefit from the hyperthermia. If you look at if down is good, right? All the other people, boom, man, they felt better for days and days afterwards. The people on the SSRIs, no change. And we've got a colleague, a guy named Chris Lowry, who's this brilliant neuroscience down in Boulder, who has been heating up rodents and studying heat as a model. He can look in their brains. Years ago, he did a study. If you put the rodents on a chronic SSRI and then you look in their brains, you don't see the effect that hyperthermia has if they're not on the SSRI. So we have some worries that maybe heat will not be as effective. Heat may work through a partly serotonergic mechanism. It may not work as well in people on SSRIs. Or maybe it will. Nobody has ever studied it. So in this study, we're letting people in not on antidepressants, and we're letting them in on antidepressants, and we'll be able to look and see is there a difference, right? So these are just 2 very, very pressing clinical issues that we think are these sort of core issues in this field of this novel treatment, and that's what we're doing there. And then, actually, this is relevant for both this and the psychedelic study. How do heat and cold work to relieve depression? What are their mechanisms? If you can understand how something works, you can understand how to best use it. And if you can understand how something works like heat, you might be able to say, well, there may be something else that does the same mechanism. Maybe this will help us invent new treatments. So I'm not going to go into the details, but we now have some evidence that when you put people in this intense heat machine, they have an immune system response that looks identical to the immune system response you see with vigorous exercise. And it's an interesting response because it has some pro-inflammatory elements. It's kind of surprising, but so does exercise. The more people get that response, the more undepressed they are 6 weeks later. So we're going to follow up on that and work, and the Morgans have really helped us with this in terms of funding. We're collaborating with SPRY, and we're going to look and see, does this heat treatment or this heat and cold treatment, does it have that signature, and then what does it have to do with things like senolytic cells and other elements that promote unhealthy aging? So there's this biologic mechanism that's also very cutting edge and very cool. All right, then let me talk for a minute about the psilocybin studies. Now, you know, it's big news. Colorado, it's hard to overestimate how much on the bleeding, crazy cutting edge of psychedelic stuff your fine state is. What's going to be done here in terms of using psychedelics as treatments is unprecedented. Colorado's essentially done an end run on the Food and Drug Administration. I never thought I'd live to see such a thing, but here we are, right? So there's going to be some good that comes of that. There's going to be some challenges that come from that. It's going to be wild. Vail has an opportunity to be a responsible voice in this space and to figure out how can we best use these agents in a safe, clinically effective, responsible way in an environment where they're going to be widely used. So we're doing a study of psilocybin. We call it the Optimized study. And just to say it's not just Colorado. Other states are beginning to come on board. It is a complex study. I'm not going to torture you with the complexities. We have some of our team in the back. They're tortured enough with this. But I can tell you a little bit about what it seeks to do. So remember, we're interested in trying to see how can we make something work better? Can we understand how it works? And can we figure out who's likely to benefit and who's likely to struggle? These are these key questions. So in this study, can we use novel methods to make the psychedelic work better and to work longer? So, you know, when you take a psychedelic, the way it works in these studies is you come in, you see us, I give you a high dose of a psychedelic, you have this powerful experience. Many people get a tremendous benefit from that, and then they're wandering off, the drug's out of their body after 6 hours, and then, you know, are they still depressed? Are they still undepressed a month later, a year later? You know, generally people do well for a while and then they begin to get depressed again. Are we going to be giving people psilocybin for the rest of their life? Wouldn't it be nice if we could find some way to make that one treatment work better? So we're going to pair it with a very cutting edge technology called vagus nerve stimulation to see if we can sort of cook in the benefits of the treatment with psilocybin so that people get more undepressed, stay undepressed longer. Can we understand how psychedelics affect the way how people live their lives? You know, there's a lot of discussion about psychedelics maybe helping make people more social or more kind of loving and this sort of thing. We're collaborating with the world's leaders in this space at Emory University to actually study what psychedelics do to people's real-world daily behavior. We have a little secret listening device that people wear. It's really fascinating. So we're looking to see, does it change how people live their lives, and does that explain why people get undepressed? And then, can we better identify how to use psychedelics more safely? We are going to do, by a factor of about 100, the most rigorous evaluation of people's mental state in the weeks before they do a psychedelic and in the weeks after they do a psychedelic. We have collaborators in Europe who do this wild mathematical, complex, dynamical systems modeling that allows you to look at these very complex patterns mathematically to predict who's going to do well, who's going to do badly. So anyway, this is this optimized study, but you see these same repeating patterns of how we're doing things. Real quickly, next steps. So we've started the hot and cold studies going. So we're going to keep enrolling people. That's the chilled study. We are hard at work developing, getting FDA approval for, and then beginning, we hope this year, this optimized study with psilocybin. We're developing additional studies. We were meeting this morning with the team to talk about ideas. There's all sorts of very cool ideas that branch off of what we're talking about now, with a focus, of course, on mental health, but also we have this interest in looking at healthy aging and the health span, because the chemicals that are involved with that are the chemicals that are involved with emotional well-being. It's one thing. Talk to Mr. Dr. Lindley about that. He really has a vision on that. And then we're going to use these studies to build the necessary personnel, facility, and financial infrastructure. You remember that movie, Blocking on it, but if you build it, they will come, that baseball movie. The way to build a research institution is to do research. And so we're building it as we're doing it. We're like people out on the ocean building the ship as we're floating, trying to get to Europe. Now, this is an interesting picture, and some of you may have seen this. That is about as miserable as you'll ever see Chris Lindley in his entire life. Ashley, you have a set of protocols for what people cannot do the day of hypothermia. And what's the key thing on that, other than not getting like dirty drunk?
You're not supposed to exercise before.
And Mr. Lindley, what did you have me and our team do the morning before at 5 o'clock? Brutal exercise. And then what did you have us do after the exercise? Jump in the river. Then we jumped in the river, right? So Chris had a very difficult, challenging experience, and he's in cross-eyed, excellent shape, and it was confounding to me. And it was actually Ashley who pointed out that it's a good thing he didn't die, because. But here you can see, there's the hypothermia machine. Here's the cold plunge. He's almost done, and we're looking at him and somewhat worried about him.
Barry's not worried.
If we're working on this idea, if you are interested in experiencing this modality for yourself and see how it differs from your sauna or your hot tub, talk to us. We're working on it, but we hope to be able to let you come in. And you have to be healthy enough to do it, and you've got to promise not to get rip-roaring drunk the night before and not go to Chris's gym the morning of. But it's quite interesting, and there's no doubt, and Ashley showed these data, that this, you've never been this hot. I put myself in the fancy heckle version of it, and I was blabbing my butt off, just like we talked about. I was confessing everything. I was having a real wild experience. But the key thing, I'd never been that hot. I do a steam shower twice a day. I'm like really heavy-duty heat guy. No, right? You'd agree. No, this is different, right? So it's different. Certainly lower levels benefit you to some degree. This is a different thing. If you're interested, talk to us, because we're interested in our studies are in depression. They're in folks that are really struggling. It has to be that way, and they're the people that desperately need this. But these sort of interventions are valuable just for well-being in general. So with that, I'll stop, and thank you all for your kind attention.